My name is Matthias Bossard. I'm an interventional cardiologist at the Cardiology division of the Heart Center in Lucerne, Switzerland. I'm the head of CTO and CHIP PCI program there, and very much into clinical research trials. We need to be aware that the number of patients presenting with complex and especially calcified lesions has grown over the last few years, and we now have on hand many devices, whereas the OPN, the super high pressure and C-balloon OPN is one of them. On the other hand, we have IVL, and there are a number of other devices. But there is little trial data so far guiding us in terms of device selection. And what we've learned from a big single-arm study, the DISRUPT-3 trial, is that the IVL is super safe to use in calcified lesions. But this trial also indicated that it might be effective, but it had never been appropriately tested, and that's why we decided to undertake a trial comparing the super high pressure and C-balloon OPN to IVL, because in our own experience, we saw that OPN could be a fair competitor to IVL, since it, in our practice at least, appears effective and also safe. That's why we decided to compare them directly. So it was actually a very simple trial. We randomized patients in a one-to-one fashion to either IVL or OPN. Ultimately, we came up with a sample size of 280. The trial was powered for a surrogate parameter, which was stent expansion assessed by OCT. And the patients, following randomization, they underwent a procedure. We guided the involved physicians to not cross over from IVL to OPN and vice versa. A patient underwent lesion preparation with the assigned study device, and following stent implantation, they could undergo post-dilatation with regular NC balloons, or if they were in the OPN arm, they could also use OPN for post-dilatation, and whereas this was prohibited in the IVL arm. And there was a final OCT run, which was used for assessment of the primary outcome. Following enrollment and study procedure, the patients had a clinical outcome assessment at 30 days, and we will have those patients undergoing a clinical follow-up up to 2 years, and we'll publish that data at a later stage. The key findings were actually, in terms of the primary outcome, which was stent expansion in percentage assessed by OCT, was that there was no difference, that the OPN was non-inferior to IVL. We also tested for superiority, but that was not met. But still, we could show that the cheaper device, OPN, was non-inferior for stent expansion. With regards to safety outcomes, there was no significant difference for major periprocedural complications, including perforations, no reflow, and periprocedural MI. With regards to clinical outcomes up to 30 days, also no differences for MACE, target vessel revascularization, or any other clinically relevant outcomes. And I think that's big, because it indicates that a rather simple balloon-based device could challenge the more technical device, IVL. So that was also surprising to us, because we were, to be honest with you, seeing the trial data for IVL coming from the DISRUPT study, as well as many other registries and smaller studies which have been published, which all indicated that IVL is safe. We knew it would be risky to compare the super high pressure OPN balloon, which you basically can take up to 40 atmospheres, and that's a value where most interventional cardiologists probably never go in terms of inflation pressure. We knew that would be risky, and in our trial setting, we saw no difference. The number of perforations was very low. We did not have one single case where we had to drainage the patient for pericardial effusion. There was actually one major perforation in the IVL arm, which could be handled in the cath lab, but otherwise of that, no significant difference in terms of safety outcomes. It will change the perception of IVL. Since our study indicates that you can safely use the super high pressure balloon for many lesions, for many kind of calcified lesions. What we also observed, and I didn't mention that before, is that you might also save some time by using OPN in compared to the IVL, which requests a generator attached to the device to keep it going. By using the OPN, you save up to 10 minutes in procedure time. And I think that's something, if you're doing as a cath lab, a lot of cases, that's key. We also saw that the number of devices which you use to deliver the study device, which was IVL or OPN, was much lower in the OPN arm compared to the IVL. This also indicates that you might use less devices if you use an open-based strategy for tackling calcified lesions. Ultimately, what we can conclude is that OPN is not just a safe alternative, but also an effective alternative to IVL, and which is probably related to less cost. We need to take into account that our trial, the Victory trial, investigated native calcified coronary lesions in mainstay lesions. We excluded ostial lesions. We also excluded calcified instant restenosis. And I think there we will need more data to see if the OPN also is as effective as IVL. On the other hand, also something that's upcoming is lesion preparation in terms of drug-coated balloons for lesion treatment. We'll need to learn more from future trials if IVL might there has more room, because what we also observed in our study that following lesion preparation, you end up with more dissections by using a balloon-based approach with the OPN in comparison to IVL. So, I mean, for those three things, lesion preparation in ostial and lesion preparation in instant restenosis, as well as for DCP management of calcified lesions, will need more studies comparing IVL to other devices. And there's also a question which we would love to embark on is if the combination of IVL with OPN or other devices might provide you incremental lumen gain or actually stent expansion, which in turn then translate into better outcomes.